This video will be used to illustrate an extraction and many of the different tools and techniques we use at Jungle Roots Children's Dentistry. First of all, of course, greet your patient, lean them back, get them comfortable. We'll be using nitrous oxide for this particular procedure. Here's the nose piece. It's already hooked up. It has a triangular shape. The apex of the triangle, as Tammy's now demonstrating, belongs at the bridge of the nose, not the opposite. It's designed to fit well and create a nice seal so that there's no escape of nitrous oxide. We can make our nose smell in a number of different ways. We have little oils, scented oils, that the child will pick a flavor of their choice or smell of their choice. We'll put a little material on the cotton tip applicator and gently and accurately swab it on the inside next to the outlets where the nitrous oxide and oxygen emanate. Do not take the swab and just swab it vigorously inside. Some of the material can get caught on the child's nose, making their nose very irritable, and are constantly requesting the nose to be removed for comfort so they can scratch their nose. Go ahead and secure the tubes from behind with the plastic sleeve. That makes it nice and snug but not too tight. And go ahead and turn your oxygen on first. Usually want between 4 to 6 liters of flow total. The balls float, telling you specifically at the numbers how many liters per minute they're flowing at, and if they're all both at even, you know you're at 50%. There's two types of needles. We have the clear ended needle and the opaque ended needle. The clear is a short used for mandibular blocks and certain injection techniques. The opaque is an extra short used for tight spaces. To load a syringe, you simply load the cartridge. You then twist off the bottom portion, accurately and gently screwing the active end of the needle into the tip. And then you want to engage the harpoon, which is a sharp area that engages the plastic area in the syringe itself that's used for aspiration, and then take the lid off and express some of the material to make sure that you actually have a correct loaded syringe. To recap it, do not get your fingers next to the ends. Scoop it up from the tabletop. Once it's basically on, then you can finish it up. When we load the other syringe, basically the same thing again. Retract, load your cartridge, and in this case she's going to engage the harpoon. Again, the plunger is what the harpoon is engaging. Excuse me. Then we screw in the needle. This is the extra short, usually used at the end of an extraction procedure. Again, remove the cap to verify that the syringe is correctly loaded and the material is expressed. There we are. Good. And cap accordingly. This is the safe way to cap, otherwise you might run the risk of injuring yourself. We're air drying the area to place the local anesthetic for an infiltration. We use our super topical, and it's very important not to rub this material into the tissue very hard. You can numb it very quickly and unfortunately be very aggressive in removal of the tissue. It gets very bad up there. You can get it in a really bad canker sore. The syringe is passed. Clearly the tip is on because I'm not really injecting, but the assistant is placing the hands over the child's hands to make sure there's no extraneous movements. I then express the local anesthetic into the correct location, pass it back to the assistant, and we go ahead right away and provide some water. We don't want that topical anesthetic on for too long, and the material certainly tastes pretty bad too. This is a demonstration of what's referred to as a mandibular block. Topical is placed in two very strategic locations for this. When the child opens their mouth really wide, it'll form a triangular shaped area in the corner of their mouth, hopefully visual here. There it is, but immediately in front of my thumb, that's where the local anesthetic or the topical anesthetic is placed, and in the buccal fold adjacent to the very back molar for the residual of the local anesthetic administration. Please make sure that both of these areas are properly coated with the topical anesthetic before we're ready for the injection. We always have kids stay open really wide with the use of a malt prop. I call it a tooth pillow because it sounds a little bit nicer. So the child opens themselves, and then we approximate the size of that opening with the malprop itself. A dry 2x2 is essential in this particular area to grab a hold of the tissue properly. Then the local anesthetic syringe is passed, and typically a shaking motion is used to distract. The local anesthetic is administered both for the block and right now, as you can see, for the long buckle, which is anesthetize the tissue to the outside. Once finished, local anesthetic syringe is passed to the assistant, and of course copious amounts of water are placed. Once local anesthetic has been achieved, we're ready to actually perform the procedure. While we're waiting for the local anesthetic to work, we lower the nitrous oxide down to about 40 to 35%. Once we're ready to work, we bring over the trampoline, which is that little piece of cotton. I go ahead and hold on to the tooth tightly and deliver the tooth from the mouth. Once the tooth is delivered, a 2x2 folded up on itself a number of times is placed over the extraction site. The child bites down firmly. Post-operative instructions are provided. During that time, the child breathes 100% oxygen to reverse the laughing gas, and notice that oxygen was boosted up to reach the optimum levels of 6 liters of flow. Thank you for listening.